Is there a laser pointer by any chance? I'm not sure that the one up there is working.
So,
but this is all set?
yeah, well,
Okay. That usually that other one, yeah.
there's
Oh, it is working.
two.
Sorry.
So the front
Oh,
button here,
I got it.
But, you know, it records the slides.
Yeah.
So if you move this one. Yeah.
But this will do the slides also, right?
Yeah, that'll do it. But, like, for people who watch the video after, they would see your pointer moving if you use this.
Oh, so that's better.
To.
Oh, I got it. I got it. Okay, that's fine. Okay. So we're okay to go, or?
Yeah, whenever you're ready.
Okay. Good afternoon, everyone. I think we'll begin. Welcome to this lecture on calcium homeostasis, part 1 of calcium and metabolic bone disease in the endocrine system course, so nicely put together by Dr. Eric Epstein. And there should be passing around. It hasn't made its way very far. It's right about here. A little 2-page document, which is not in your handout, not in the slides, not to panic. I'm going to come to it at a point much later in the lecture. I really would like you to just take a cursory look at it. There's nothing in terms of content there that I want you to see, but it is relevant as an example of some of the challenges we face as physicians nowadays. This is information for patients on hypoparathyroidism, and it comes from one of the organizations that includes endocrinologists, the Endocrine Society. There actually is such a thing. And they try to provide educational material for patients to recognize what symptoms are, what the problems are, even in relatively rare diseases, as in this case, hypoparathyroidism. And you're going to face individuals who will come in, if you're in an office setting or even in a hospital setting, etc., who've been through the internet and every website imaginable and may know cutting-edge things about certain diseases and challenge you with, well, doctor, why aren't we doing this or that or the other thing? And then at the other end of the spectrum, as part of health disparities, you have people who are functionally health illiterate. They've had no access to this kind of educational material. And if you're dealing with something like type 2 diabetes, that kind of health illiteracy is potentially lethal and a cause of poor control, complications, etc. So the spectrum of health literacy among patients we deal with, and I'm just circulating that just to give you an example of the relatively sophisticated information being put out there, in this case by quite a legitimate, vetted organization. At the same time, in today's Science Times, New York Times, there's a lengthy article about rogue stem cell clinics. Realize this is a little off the topic, and we'll get to the lecture, but there's another example. Unmet needs, people with diseases like amyotrophic lateral sclerosis, Lou Gehrig's disease, patients desperate for cures. Someone in Tijuana, Mexico says, we'll give you stem cells and you'll be cured. Charlatans often, no evidence base, outrageous, beyond U.S. FDA regulatory control. So some of the real world situations that we face as physicians. But now on to the lecture. And the theme of the lecture in a more broad sense, besides the specific context, something which has obsessed me throughout my own career, which admittedly was more focused on research than patient care, although the area I'm speaking about is the one area where I actually did interact with lots of patients with hyperparathyroidism, hypoparathyroidism, etc. And that is the integration of basic science information with clinical medicine. The typical plea we hear, you're now in your second year, right? You're sort of at the start of the second year. And we just had the incoming class of 2017. And let me at the patients right now. I want to see the patients right now. There's another new medical school where every student has to be an EMT as part of their initial training. So you better believe they've got patient time. But is that actually critical thinking, reasoning, etc. I'm not in any way denigrating nurses, nurse practitioners, physician's assistants, all of the above, all valuable health allied professional colleagues, and we should all work with them as part of a team. But what differentiates you as a well-educated, well-trained physician is that you need to understand the scientific basis for the symptoms, diseases, etc. that you're going to see. And yes, you also have to be aware of the humanistic aspects. So it's a tall order. All these have to be integrated, and I'll sound some of those themes during the course of the talk. So let's first, just to set the stage, there are two parts to this calcium metabolic bone disease. In this part, I'll be speaking about overall concepts of extracellular calcium homeostasis and the disorders in which, typical endocrine fashion, the calcium goes too high or the calcium goes too low, the differential diagnosis and the therapy. Dr. Tabai will speak in the ensuing part 2 about various metabolic bone diseases, including osteoporosis, a major common public health problem, particularly postmenopausal women, something called osteomalacia, Paget's disease of bone, and related entities. Everything we tell you is important, right? But this is important. Why? Because hypercalcemia, which we'll dwell on at some length, is really a relatively common medical condition. This is something that you're very likely to see. Severe hypercalcemia can be life-threatening. And effective therapy is possible. But you really have to make an accurate diagnosis to be able to definitively treat the disease. Hypocalcemia, in contrast, is actually relatively rare. But it can be very symptomatic. It can be seen both in pediatric and adult practice. And again, you really need to make an accurate diagnosis to definitively treat. So this is important. The lecture objectives, key to text if you're still using that, and there's online material available. We want to understand the importance of ECF, extracellular fluid, calcium. It's a divalent cation homeostasis. The two principal calciotropic hormones are vitamin D and parathyroid hormone, PTH. We need to understand their synthesis, regulation, metabolism, and their actions, because that's really the scientific basis of understanding these disorders. We need to understand the differential diagnosis and treatment of hypercalcemia. Primarily, the main cause that we're going to focus on is hyperparathyroidism, and also its treatment, which, generally speaking, involves surgery. So any budding surgeons out there, this is a disease that is primarily treated surgically. We need to understand the differential diagnosis and therapy of hypocalcemia, and in particular, hypoparathyroidism. So let's begin understanding about divalent calcium ions, and I call it the action electrolyte, and the reason is bullet number 3. Calcium inside the cell plays a critical role in nerve firing, muscle contraction, and the secretion of various hormones. There's something called the Lasker Awards given out annually. These are the American Nobel Prize, so-called. And the Basic Science Award this year, just announced yesterday, and there'll be a luncheon I get to go to at the Pierre Hotel on the 20th for the awards, is going to Richard Scheller, actually a scientist at a company, Genentech, in San Francisco, and Thomas Sudhoff at Stanford. And they elucidated the mechanism by which exocytosis and neurotransmitters and hormone granules are all released, and calcium ions play a critical role in that process. It is the major divalent cation in the extracellular fluid, in contrast with magnesium, which is the major divalent cation inside cells. So magnesium inside, calcium outside, univalent cations, potassium inside, sodium outside. And in concert, those four ions play the key roles through ion channels, transporters, and for calcium, that plays out in multiple ways. The calcium ion itself is an intracellular signal, or so-called second messenger. Certain receptors, so-called G protein coupled receptors, are coupled to effectors which lead to an increase in intracellular calcium. So it's a signaling molecule. It also is an enzyme cofactor. There is a calcium binding protein inside cells called calmodulin, which undergoes a shape change as a function of calcium binding, and then that calcium-bound calmodulin is like a tool that gets glommed onto a variety of enzymes, several, and activates those enzymes. And then it's also a structural component. Our bones are cellular, but there's also a matrix they're embedded in. You'll hear a lot more about this in the subsequent lecture. And that matrix is mineralized, and the mineral that's there is primarily something called hydroxyapatite, which consists of calcium and phosphate. So we haven't mentioned phosphate up to now, but phosphate is an anion that is a critical part of this story, as we'll see. And even though most of the direct regulation is on the calcium ions, there are phosphate regulatory entities as well. And they're all important because we're walking around with these bones, the skeleton, which is like a big reserve bank of both calcium and phosphate. Bullet number 4, hypocalcemia favors membrane depolarization. You've learned about this, I hope, through your first-year lectures. And in a variety of lectures, you should have learned about the depolarization of membranes, which leads to changes in sodium flux through sodium channels. And the hypocalcemia really increases excitability by favoring membrane depolarization. And in the extreme form, it can lead to seizures, something called tetany, involuntary contraction of muscles. And that's through indirect effects on sodium channels. In contrast, hypercalcemia favors membrane hyperpolarization. That is, a resistance to nerve firing or muscle contraction. Reduced excitability at the extreme, coma. You have someone with severe hypercalcemia, they can die comatose because of this dulling effect, as it were, of high extracellular calcium. So let's get a better understanding of what you measure when you do a blood test and you measure a so-called total serum calcium. What you're measuring is about 50% the actual ionized calcium. It's about 50% of the total calcium. It's hard to measure in clinical practice. In an ideal world, that's the part we care about. One would actually do ionized calcium measurements. It requires specific electrode. It requires collecting the sample under very specialized conditions. It's not something that you can do easily in routine clinical practice. So we do our best by taking into account the other forms of calcium in the ECF. The majority of it is protein bound, and the majority of that is bound to albumin, an abundant protein in the blood, about 40%. And then some hangs around in so-called organic complexes with citrate, with phosphate I've already mentioned. That's about 10%. And so there are little nomograms or algorithms for correcting the total serum calcium to get a rough index of what the actual ionized calcium is. As you could imagine, if you have changes, the last bullet, in serum protein, for example, a person has a malignancy, they have cachexia, their serum albumin is actually quite low. You may measure a total calcium, comes back from the lab, normal. Is it really normal in terms of the ionized calcium? No. That person could be hypercalcemic in terms of ionized calcium, but the total calcium appears to be normal because the low protein albumin is masking the fact that the ionized is elevated. Another parameter that's important is pH. Acidosis increases the ionized calcium. Alkalosis decreases the ionized calcium. This is actually seen in a routine clinical practice. Someone is very anxious, hyperventilating. As a result of hyperventilating, they're blowing off carbon dioxide. They make themselves alkalotic, that is, the pH goes up. What is that going to do to the ionized calcium? Drive it down, the person may actually go into tetany. And it's not that they have a primary calcium metabolic disorder, it's simply the effect of the alkalosis. So you need to be aware of these parameters. So let's take just an overview sketch of calcium regulation. And we're looking at several compartments. In the rectangle with the diagonal stripes is, and I'm going to use this pointer when I point, is the extracellular fluid calcium. And it's quantitated at about 900 milligrams. So where can that calcium go? It can exchange with at least 3 compartments. First, let's look at the gut. The gut is where you absorb calcium from the diet, and you actually excrete it in the form of feces. And in this idealized diagram, the delta between the 1,000 milligrams on average that you've taken in and the 825 milligrams that's excreted is 175 milligrams that you actually put into the ECF. Vitamin D is the key regulator of gut absorption of calcium. That will become critical. Where else can the calcium go? Well, it can be peed out in the urine. Every day, your glomerular filtration process is filtering as much as 10,000 milligrams of calcium. But a substantial amount of that, the majority of that, 9,825 milligrams in this idealized picture, is reabsorbed by the kidney. And as a result of that, the urine excretion is 175 milligrams, which in this idealized picture just matches exactly what you've absorbed. So this person is in balance, and this person is further in balance because the third place where the ECF calcium can go is in and out of bone. And that's a dynamic process. That isn't static. Every moment, every day, calcium is moving from the ECF into bone and vice versa. And you see that here, it's balanced. Now there are things that can perturb that balance. You were skateboarding. You shouldn't have tried that triple flip or whatever. You fell and fractured your tibia. You're now in a cast. You're still relatively young, something I can say about you, as opposed to present company. And as a result, your bones are still pretty actively metabolizing. It's not all downhill. It's, up and down. But if you're now immobilized and in that cast and you're lying there after the skateboard accident, immobilization, lack of gravity, favors dissolution of bone calcium into the ECF, as opposed to building new bone. A bizarre example of this, not so bizarre, but it's not something you think about. What about astronauts? They didn't break any bones. They have a problem with calcium in the skeleton? I'm seeing nodding, yes they do. You know why? There's no gravity in space. You actually can measure this. They have had substantial skeletal demineralization if they're out there for any period of time. It'll be one of those problems that has to be solved if people are really going to go up there for any great length of time. So the upshot is that immobilization can actually lead to substantial dissolution of bone calcium. Where would that go? It could go into the urine. You could get hypercalciuria, and you could get serious problems as a result. You could even get hypercalcemia as a result, although there are mechanisms to try to defend against the hypercalcemia. So that's the overview of calcium regulation. Now, let's look at our calciotropic hormones. Parathyroid hormone, or PTH, is the first one we want to deal with. It is a peptide hormone. Like many peptide hormones, It is synthesized in a precursor form called pre-pro-parathyroid hormone. There are parts at the amino terminus that are cleaved off, and eventually the mature hormone is secreted from these 4 little glands, these little black dots, that are in normal people with normal embryologic development, present, roughly speaking, at the upper and lower poles of each side of the thyroid gland, which is schematically represented here. Hence, parathyroid, near the thyroid. Parathyroid hormone acts on a G protein-coupled receptor that's present in kidney cortex, not medulla, kidney cortex, and in bone osteoblasts. And PTH, through signaling mechanisms, acts on the kidney to increase calcium reabsorption and to decrease phosphate reabsorption. So that is, PTH is one of the things bringing back lots of that calcium from the glomerular filtrate, but peeing out more phosphate. In contrast, in bone, the effect is to increase calcium and phosphate, ultimately through release of mineral from bone. Now, here is a slightly tricky issue, which is, however, clinically important. At extreme levels of hyperparathyroidism, one gets severe bone demineralization, even a disease which you'll likely never see. It was the early classic form of hyperparathyroidism. I have seen a few patients with this. It's called osteitis fibrosa cystica. Severe bony demineralization. Actually, one of the patients I saw at NIH, a relatively young woman who was so demineralized because of the hyperparathyroidism that her young daughter hugged her and ribs broke, etc. So we would think that the only effect of PTH is to cause dissolution of calcium from bone. But it turns out that PTH actually works directly on osteoblasts, which are the bone cells that build bone. And in fact, in appropriate doses, given at the appropriate time, parathyroid hormone is actually anabolic for bone and is in fact used therapeutically for osteoporosis. And you'll hear about that in the osteoporosis lecture. So that is a paradox. The same hormone, which in excessive amounts can cause dissolution of bone mineral, in appropriate amounts actually is anabolic for bone. Now, another wrinkle is something called PTHRP, parathyroid hormone-related protein. Just a show of hands, not the clickers. I don't have a question on this. Anybody even hear of PTHRP? Come on. Really? Okay. So let me then put this in perspective. This is a discovery of an important protein factor. As the name implies, it's related to parathyroid hormone, and it was discovered out of pure clinical research. A colleague of mine, we were house officers together at the Mass General, Art Broadus, was studying people with hypercalcemia of malignancy. These people had cancer of some form, and they had severe hypercalcemia, moderate hypercalcemia. What could it be? As we'll get to, I'm getting ahead of the game. You measure parathyroid hormone in the bloodstream, undetectable. Specific radioimmunoassay for parathyroid hormone, undetectable. So it's not parathyroid hormone from the parathyroid glands. It's not ectopic parathyroid hormone secretion, which almost never occurs. But there was a biologic marker which was just as if parathyroid hormone is acting on the kidney. And that is the so-called second messenger, cyclic AMP, which in response to PTH action in the kidney cortex, for reasons we still don't understand, flows out in the urine. And these individuals with humoral hypercalcemia of malignancy, undetectable PTH, very high urinary cyclic AMP. Conclusion: there must be something related to parathyroid hormone that has the same biologic activity but is not parathyroid hormone itself. That led to the discovery, and in fact, Genentech, the company I mentioned a moment ago, they were one of the ones who isolated and cloned it, this peptide hormone called PTHRP, which at the amino terminus is very reminiscent of PTH, but which is a separate gene product. It's actually a paracrine factor that's very important in early bone development, and we won't go into it further. But for reasons that aren't clear, many malignancies will secrete PTHRP. And if they secrete it to a sufficient degree, you'll get hypercalcemia. And here's the twist. As shown here, the same G protein coupled receptor that PTH binds to binds PTHRP. In fact, it's called the PTHRP G protein coupled receptor. So hence in the kidney, it raises cyclic AMP. That was the basis of the observation. So you need to be aware, and the main reason for being aware of this is in the differential diagnosis of hypercalcemia. And we'll re-amplify that. Now, our second player is vitamin D. Truly a misnomer. It is not a vitamin. It is a steroid hormone. And its structure, which I won't bore you with, is reminiscent of cortisol and androgens and estrogens and other steroid hormones. And in fact, it acts in the same mechanistic way. It is a nuclear transcription factor binding ligand. So it gets inside the cell, in the nucleus. It's a fat-soluble entity, and it activates a specific vitamin D receptor, which in turn regulates gene expression of a certain variety of proteins in a wide variety of cells. It is the major regulator of GI calcium absorption. It's critical for normal skeletal mineralization. So you'll hear about rickets and osteomalacia in the next lecture. And that's a classic manifestation of vitamin D deficiency, whether in adulthood or pediatric. It's involved in PTH secretion. And it has other non-calcemic effects. It turns out a colleague of mine at the NIH, Steve Marks, studied individuals who are completely resistant to vitamin D. Why? Because that receptor I was referring to had a mutation. So it's a rare genetic disease. And these were kids who were bald. So it turns out that you actually need, for normal hair growth, vitamin D. Now I'm just going to, in one or two sentences, tell you the following. There is a vast and growing literature on vitamin D and vitamin D levels in a yard-long list of clinical conditions, many of them very common. Cardiovascular disease, diabetes, just the list goes on. And every one of these studies, many of these studies, basically are epidemiologic kinds of correlational, don't prove causality studies, claiming that low vitamin D predisposes you to this disease and to that disease, etc. Now, evidence-based medicine, that's not good enough. To really show that's meaningful, you'd have to take a controlled trial, give some vitamin D, others don't give vitamin D, and show that it makes a difference. And without being dismissive, the door isn't closed to this, that has not been done to my satisfaction for any of these diseases. So I'm just alerting you to the fact that there is a broad and controversial literature about the role of vitamin D insufficiency in many other non-bone calcium-related conditions. In other words, that's what I mean by classical or non-calcemic effects. There are other kinds of things that vitamin D may regulate. So be aware of that. Now, what is the pathway here? The reason it's not a vitamin, yes, there is so-called vitamin D2, which really comes from plants, ergo calciferol. It's in fortified milk, it's in fish oils, and you can absorb it in the gut. So you can get vitamin D that way. But the endogenous way to get it, D3, or cholecalciferol, is UV light acting on the skin. So this is where the dermatologists worried about melanoma and skin cancer, and endocrinologists, metabolic bone people, go to war and fight and say, you know, you need vitamin D, you need to get out in the sunlight. No, you should have total sunscreens, don't ever get out. And I'm exaggerating, obviously, and you know, there are other ways to get your vitamin D, but it is a situation. People of color are uniquely, obviously, predisposed to have less vitamin D because the melanin pigmentation. People moving from South Asia to the UK often happens. They're walking around now fully clothed, with every inch protected because it's cold, foggy, rainy in London, etc. They're at risk for vitamin D deficiency. So these are issues. And by the way, the Eskimos, kind of an anomaly as you go further from the equator. They have a very fish oil rich diet with a lot of exogenous vitamin D. So it's kind of an exception to this. The upshot is that vitamin D, whether you get it from the gut or the skin, has to be converted, and that's done in the liver, to 25-hydroxy vitamin D. That's a pretty unregulated step. On the other hand, in the kidney, under physiologic conditions, there's an enzyme that then adds another hydroxyl group to create the active hormone. The active steroid hormone that binds to the receptor with high affinity is 1,25-dihydroxy vitamin D, and that is carefully regulated. Parathyroid hormone stimulates the 1-hydroxylation. Hypophosphatemia stimulates it. Now, things get out of whack sometimes, and there are granulomatous diseases like sarcoidosis, like TB, other granulomatous diseases, and they're rich with monocyte macrophages, and it turns out that those monocyte macrophages can actually have 1-hydroxylase activity and can form unphysiologically 1,25-dihydroxy vitamin D. As a result, you can get hypercalcemia in these granulomatous conditions, which is due to unregulated formation of 1,25 vitamin D. Okay? And that is part of the differential diagnosis then of hypercalcemia under those conditions. So here's our first question. Vitamin D is an essential nutrient that must be ingested in milk and other foods. True or false? And I'll leave the polls open. Please vote early, but not often, because that doesn't work. I'm judging we should have roughly 100 responses, but maybe not. Okay, let me just call the question. 98% of you got the correct answer of the 85 who responded. 2% didn't. It is not an essential nutrient, which is one of the definitions of a vitamin. A vitamin is an essential nutrient that is critical for normal cellular homeostasis, which we, as human mammals, are incapable of making endogenously on our own. That is not the case with vitamin D. If you never ate any vitamin D, in principle, if you had enough sunlight exposure, you would form enough vitamin D3 and you would have enough of it. So that was false. Another question. Vitamin D must be hydroxylated in 25 and 1 positions to generate the most active form. 2. Binds to a ligand-activated nuclear receptor to exert its biologic effects. 3. 1,25-dihydroxy vitamin D is produced primarily in the kidney, but can also be formed in macrophages. 4. All of the above. Okay. Great. Great work. All of the above, all three of those are principles that we said earlier. All three of those are true. So this is really getting through in a good way. So again, a summary slide. You'll see many of these schemas. This is really fundamentally what I've been telling you all along. But it just is a way of organizing your thinking. You've got the main players, the small intestine, the kidney, and bone. So we talked about that in the earliest homeostasis diagram. Then you've got the parathyroids, which are schematically shown superimposed on the thyroid gland. Let's propose you have a decrease in serum ionized calcium for whatever reason. What's going to happen? Parathyroids are going to secrete parathyroid hormone. That is going to increase the formation of 1,25-dihydroxyvitamin D, which is going to increase in the small intestine calcium and phosphate absorption. In the kidney, it's going to stimulate formation of 125. It's going to decrease calcium excretion. It's going to increase phosphate excretion. In bone, it's going to lead to an efflux of calcium and phosphate. The net effect is to restore the ionized calcium to the normal range. That's really the goal. Notice that phosphate is kind of a peculiar player in this. On the one hand, the phosphate is also going up when it's liberated from bone. It's also going up because of the increased intestinal absorption. If that happened without any other homeostatic compensation, not only would calcium go up, but phosphate would go up. Guess what? Calcium phosphate in the blood has limited solubility. You want calcium phosphate to crystallize and form mineral in bone matrix. You don't want that to happen in your arteries, in your soft tissues, elsewhere. That's really a potentially very bad condition, a very rare disease called fibromyositis ossificans, where a person becomes kind of wrapped in bone because of that kind of soft tissue. There's also a traumatic version of that with rhabdomyolysis. So that's not what you want to happen. The physiologic compensatory mechanism is the action of PTH on the kidney, which is to liberate more phosphate. So you actually start peeing out more phosphate in the urine. And that damps down these other effects. So, in summary, parathyroid hormone, 1, acts on bone and kidney to raise serum ionized calcium. 2, shows amino acid sequence homology to PTHRP, but binds to a distinct G protein coupled receptor. 3, acts directly on the GI tract to increase calcium absorption. 4, can cause hypercalciuria by decreasing renal reabsorption of calcium. Which is it? Little slower responses here. Well, Eric, we started a little late. What is our goal for time ending here? Thank you. Okay. %, the correct answer. That is true. It does act on bone and kidney, directly acting on G protein coupled receptor, and the effect is to raise serum ionized calcium. 2 is wrong because even though it does show amino acid sequence homology to PTHRP, and this is a little tricky, it does bind to the same receptor as PTHRP. I said that. Now, it's a little tricky, and I doubt that the 1% had this in mind. If you did, more credit to you. Like everything, life is complicated. There's more than one PTH receptor. There's even another PTH receptor which may not bind to PTHRP. I don't even know. Eric, I'm not sure. But the upshot is that isn't the take-home message. The take-home message really is this key PTH receptor is the same GPCR for PTH and PTHRP. Now, 11% of you were lured in with number 3, acts directly on the GI tract. The key word here is directly. It doesn't act directly on the GI tract. There are no PTH receptors of the specific kind that we're talking about that regulate calcium reabsorption from the gut. It acts indirectly by raising the value of 1,25-dihydroxyvitamin D, which in turn absolutely acts on intestinal luminal cells and actually regulates a gene for expression of something called calcium binding protein. It's a specific protein that is part of the transit machinery to bring in more calcium from the gut. So that was the crucial difference. And finally, number 4, 0% of you got it. Can hyperparathyroidism, can PTH cause hypercalciuria? Yes, it can. Even though it is helping reabsorb calcium from the kidney, if it's dissolving so much calcium from bone that the filtered load exceeds that capacity, you will get, in fact, you get kidney stones in hyperparathyroidism, and that's part of the reason. But it doesn't do so by decreasing renal reabsorption of calcium. It really acts to increase renal reabsorption of calcium, but that can be overwhelmed if you really have too high a filtered load. So that was a kind of a tricky one. So now let's look at hypercalcemia. We've got a lot of good background now. We know about the hormones. We know about the homeostatic mechanisms, etc. Let's get into the clinic. And we're seeing people with hypercalcemia, all kinds of clinical manifestations, neurologic manifestations. I'm not going to read through these. You've got them, on the slide. You can study them. And I should have said at the outset, I won't be hyperbolic and say my door is open, although I have started having lunches with students. And big deal. But and I'm always happy to meet you in the Falk Center for those who frequent the Falk Center. I've got to get some exercise and blow off steam that way. But my email box is open to you. I'm responsive. And if you have questions about any aspect of the lecture, and of course other things, although complaints, refer to your student affairs deans. You better believe that I monitor those things. And the stuff going on in front of the housing, I realize how disruptive that is. But trust me, those cracked concrete things and the puddles when it rains are ultimately unacceptable. I've been working hard this entire few years to make the place more livable, and that will happen. But like all these things, the Forsheimer corridor, by the way, isn't that an improvement? So fair enough. Oh, and by the way, the student lounge area, by next summer, trust me, there are going to be some fantastic stuff there. In any event, let's come back to this. So neurologic manifestations, unfortunately, quite nonspecific. Fatigue, weakness, very common symptoms, not specific for hypercalcemia, but can be a feature. Depression, the ultimate one, coma. The GI symptoms. These are important. The anorexia, nausea, vomiting, as you'll see, this leads to a vicious cycle because you make yourself more dehydrated and you make the hypercalcemia even worse. Renal, polyuria, polydipsia, dehydration, nephrolithiasis, and as we'll see, and this is very important, parathyroid hormone increases renal calcium reabsorption. Guess what? As we're going to see, the calcium ion itself acts on the kidney to decrease renal calcium reabsorption. Okay? It also actually inhibits, at high calciums, ADH actions, which we talked about in a lecture last year, to concentrate the urine, hence polyuria, polydipsia. So there's that vicious cycle I was talking about. And there are cardiac manifestations as well. So these are clinical manifestations. Now let's get into differential diagnosis, and it's really all summarized on this slide. You're dealing with two relatively common causes. Primary hyperparathyroidism, which is more likely to be seen in an ambulatory setting, the outpatient department. Malignancy, which is more likely to be seen in a hospitalized setting. There are certain drugs, thiazides are the most notable ones, that can actually lead to elevated serum calcium. So you do need to take a careful drug history. We'll go through hyperparathyroidism in detail, but for malignancy, let me just point out, I've already talked about humoral hypercalcemia of malignancy, which is mostly PTHrP. What that means is you don't even have to have bone metastases. On the other hand, you can have lytic bone metastases. And furthermore, there are some malignancies that actually give you the hypercalcemia through a vitamin D-like mechanism. Think about that. I said granulomas, Hodgkin's disease, certain lymphomas can mimic those granulomatous conditions and give you that condition. Uncommon forms, thyrotoxicosis, sarcoidosis, and other granulomatous diseases, other drug-induced, including vitamin D excess, total parenteral nutrition, even rarer, PHOs, other granulomatous diseases, immobilization we talked about. What's the therapy? You should think of the therapy in two forms. There's non-specific therapy no matter what the cause of the hypercalcemia. Hydrate the person. Diuretics, not thiazide diuretics, to flush calcium out. These are like bailing a leaking ship. there's some source of calcium coming into the ECF, and you're trying to dump it out through a Lasix, furosemide, and saline diuresis, but no, that'll only get you so far. The bisphosphonates are the mainstay of therapy. They are not only used in osteoporosis, as you'll learn, they effectively block bone resorption, and they, on an acute basis, will lower the calcium. But these are all non-specific measures. The specific measures are to diagnose. Is it hyperparathyroidism? You'll need surgery. Is it a vitamin D mechanism? Glucocorticoids are very effective in suppressing vitamin D-based hypercalcemia. If it's a malignancy that you can treat, by all means, treat it, and that will relieve the hypercalcemia. So this question asks, cancer can cause hypercalcemia by the following mechanisms. Number 1, osteolytic bone metastases. Number 2, ectopic tumor secretion of PTH. 3, tumor secretion of PTHrP. 4, excessive production of 1,25-dihydroxyvitamin D. 5, 1, 2, and 4. 6, 1, 3, and 4. Take your choice. Okay. 61% said 1, which is correct. Absolutely, breast cancer, several other kinds of cancer really can riddle bones with metastases, and that can overwhelm the homeostatic system. Number 2, ectopic tumor secretion of PTH. Turns out that really almost never happens. Fuller Albright, the dean of endocrinologists, Mass General back in the 40s, case CPC in the New England Journal. It was a renal cancer. It was humoral hypercalcemia of malignancy. They took out the kidney cancer and the hypercalcemia went away. Definitely a humoral substance. He postulated it was ectopic PTH. Well, guess what? He was brilliant, and that was before he had any way of measuring PTH directly. It was not ectopic PTH. And for reasons that aren't clear, that is not something that happens. Hence, number 5, for the 30% of you who voted for that, is not correct, for that reason alone. Number 3, absolutely, as I've said, PTHrP, which is not normally a systemic hormone, can be oversecreted by tumors. And absolutely, some malignancies, like lymphomas, Hodgkin's, can excessively. So the correct answer was 1, 3, and 4, number 6. Hope these questions are helpful to you. So, extracellular calcium homeostasis, bird's eye view of a parathyroid cell. This is a schematic parathyroid cell. These little granules are the secretory granules containing parathyroid hormone. And the parathyroid hormone, as we've already said, comes out, acts on bone and kidney, indirectly on the gut through 125, all of which raise the serum calcium. And it turns out that calcium ions in the blood are a hormone that bind, of all things, to a G protein coupled receptor discovered by another one of my colleagues, Ed Brown, now at the Brigham, formerly in our lab at the NIH with the late Jerry Arbach. And in 1993, he cloned the calcium sensing receptor. It's a G protein coupled receptor which is activated by calcium. And it has the effect, and this is so confusing, so bear with me. Activation of this receptor inhibits parathyroid hormone secretion. It's a double negative. Activation of the receptor inhibits parathyroid hormone secretion. That's really completely backwards to every other cell. In every other kind of situation, usually you activate a receptor and you stimulate secretion or contraction or whatever. Here you inhibit it. And that has another ramification, by the way, which is peculiar. You know, every endocrine disease is hyper this, hypo that, etc. We'll see the ramifications here. But this calcium sensing receptor, that is really a feedback, typical negative feedback loop. It's actually directly activated by the same thing that it's regulating through PTH. I hope everyone gets that. So if you have hyperparathyroidism, it can occur either as primary or secondary hyperparathyroidism. Primary is defined as excessive PTH secretion because there's something wrong with the parathyroid glands. They're not doing what they're supposed to do. So you get hypercalcemia, hypophosphatemia. On the other hand, secondary hyperparathyroidism is quite physiologic. Something else is causing hypocalcemia. The most common thing would be chronic renal failure. Secondary hyperparathyroidism is one of the most important clinical aspects of end-stage renal failure. So hypocalcemia will not activate the calcium receptor, hence you lose this inhibition, hence there's PTH secretion. Now, let's hone in on primary hyperparathyroidism, both its diagnosis and its treatment. The differential diagnosis of hypercalcemia is actually fairly straightforward. Check the parathyroid hormone by a reliable radioimmunoassay. Be sure you understand the patient's renal status, because if the person has end-stage renal disease, then you expect the parathyroid hormone to be up. That's secondary hyperparathyroidism. Check the 25-hydroxy vitamin D level. In practice, we don't measure plain old vitamin D typically. We typically don't measure 125, although it can be measured. We measure 25-hydroxy D as sort of the most standard measure. And the reason we measure it, you could have what's called normocalcemic hyperparathyroidism. This is increasingly discussed and recognized. That is, a person whose calcium isn't actually above the nominal upper limit. But if the person's calcium is repeatedly in the 10.3 range or whatever, with 10.5, the nominal upper limit, that's actually not likely to be normal, and particularly not if the PTH is either at the high end or overtly elevated. If that person is a little vitamin D deficient, as measured by 25-hydroxy-D, then there's an element of masking of the hypercalcemia by the vitamin D deficiency. The hyperparathyroidism may come as a sporadic form. Very rare to have parathyroid cancer. Very rare. More typically, a benign single-gland adenoma, a benign neoplasm, which nonetheless hypersecretes PTH. On the other hand, there are several genetic diseases that cause hyperparathyroidism as part of their manifestations, and invariably, all parathyroid cells, all 4 glands, or even more, are involved, hyperplasia. Now, one of the biggest conundrums is asymptomatic hyperparathyroidism, the most common thing that you'll see now. A person is not coming in with kidney stones. They're certainly not coming in with dissolved bones like the classic thing, but they've been measured on an electrolyte scan, the calcium's up, you measure the PTH, lo and behold, they have mild hyperparathyroidism. There are various consensus statements, guidelines for the management, skeletal effects of intervention. I'll give you the references here. Ultimately, and we'll go into this further, you have to decide, should the patient have surgery? And even if the person is going to have surgery, the traditional approach, general anesthesia, explore the neck bilaterally, remove the offending gland, or minimally invasive. Some preoperative localization by ultrasound, that's most typical. And then the ultrasound, there's something called a sestamibi scan, and that's a little more sophisticated, may show you there's one big gland on one side. Then in principle, the surgeon may actually do this under local anesthesia, remove the offending gland. There's actually a way intraoperatively of measuring PTH and seeing that it's normalized and say, end of story. Now, why would you be that kind of minimally invasive? There's some dangerous things here. There's the recurrent laryngeal nerve, which if you bag one of them can give you hoarseness. If you bag both, the person's in serious respiratory embarrassment. They control the vocal cords. If you take out too many parathyroids, you'll now make the person hypoparathyroid. So those are some of the vagaries. There is a drug. It's called cinacalcet. It is a so-called allosteric modulator of this calcium sensing receptor. Long story short, it actually tricks the calcium sensing receptor into thinking that there's more calcium bound than there actually is. If you're looking at a dose-response curve, what it's doing is left shifting the dose-response curve for activation of the receptor relative to extracellular calcium. What would that do? That will inhibit PTH secretion. It is FDA approved for treatment of secondary hyperparathyroidism in end-stage renal disease. So you can logically understand that. But it has been used, as shown in this illustration, to reduce serum calcium and PTH in people with intractable primary hyperparathyroidism. Intractable, they were not operative candidates for whatever reason. So in principle, you should be aware that there is this agent. But it is still not the standard practice for people with conventional primary hyperparathyroidism who could be treated surgically. I'm not going to go through this laundry list. Again, happy. Anybody who's enthusiastic about what's on this slide, I'll be happy to speak with you endlessly. We'll have lunch. We'll go into detail. I'll show you pictures on my wall about cloning the MEN1 gene, etc. But the point of the slide is there are several hereditary forms of hyperparathyroidism. The take-home message is you're seeing this patient for whatever reason. If this is a relatively young person, by that I mean even someone in their 30s, certainly someone in their 20s, that's not typical for hyperparathyroidism. Be suspicious of hereditary disease. Person tells you that their aunt had kidney stones or had a neck operation. Be careful family history. Beware of familial forms of hyperparathyroidism because it has ramifications for multi-gland disease, not single-gland disease. The surgeon needs to know this. Has ramifications for family screening. It comes in multiple forms, MEN1, MEN2, something called the hyperparathyroidism jaw tumor syndrome, something called familial hypocalciuric hypercalcemia, and even possibly familial isolated hyperparathyroidism. I've listed genes responsible. I've listed pathogenic mechanisms, associated clinical features. Not time to go through these, but as I said, happy to discuss these in more detail. We will go into one example, though, which is important to recognize. Familial hypocalciuric hypercalcemia is actually due to a loss of function mutation in red of one of the two alleles, one of the two genes, you get one from your father, one from your mother, for the calcium sensing receptor. That has the effect of right-shifting the dose-response curve for calcium activating the receptor. If you right-shift, that means you have less inhibition of PTH, you have more PTH secretion, therefore it acts on kidney and bone and raises the calcium. So you have hypercalcemia, inappropriately elevated PTH because of this loss of function of one copy of the calcium sensing receptor. What's the hypocalciuria all about? They have relatively low urine calcium for the filtered load of calcium. And the reason for that is, and it alludes to what I said earlier, this calcium sensing receptor is actually present on renal cortical cells, where calcium directly activates it and causes less reabsorption of calcium. So if you have one loss of function mutation in the kidney, the effect is that calcium is less effective at making you excrete the calcium, so you're relatively hypocalciuric. That's the critical diagnostic test. A calcium in the urine to creatinine in the urine ratio. There are algorithms for what the numbers should be. How should you be suspicious? Family history again. Why is it critical to recognize? Don't operate on these patients. You will not cure them, trust me. We tried back when we first recognized this disorder in the 70s. Every piece, every cell has the capacity of hypersecreting PTH. So unless you make them totally hypoparathyroid, which is not a good thing, you will not cure them. Plus, this doesn't have any major ramifications, does not cause kidney stones, does not cause bone disease, etc. So that's important to recognize. I'm going to gloss through this, and what I'm going to say is this is sort of, whether this makes it onto the board exam, I don't know how quick they are to do that. Again, anyone interested in more detail here, happy to tell you, but the upshot is this fills in the blanks in that parathyroid cell. I've already told you that calcium directly activates the calcium sensing receptor, leading to decreased PTH secretion. This is telling you internally in the parathyroid cell how that likely happens, and it's pointing out that right downstream of this G protein coupled calcium sensing receptor are two G proteins called GQ and G11. Meaningless terms, I recognize. Why am I boring you with this? Self-promotion? No. I'm just telling you about an editorial recently written in the New England Journal apropos of both an article from the UK my colleague Raj Thacker at Oxford, and a letter from the MGH much about the same thing. Mutations affecting G protein subunit alpha 11 in hypercalcemia and hypocalcemia. And what the issue is here is that just as FHH can be caused by loss of function mutation of the calcium sensing receptor, it can be caused, it turns out, by loss of function mutation of alpha 11. So it doesn't make any difference whether it's the receptor or the G protein downstream. And we can go into why that is, etc. Realize I glossed over that rapidly, but anyone interested will give you more detail. The point is, it's obviously a relatively rare cause of an already rare disease, but it is important to recognize, and conceptually integrating your signal transduction and basic science. So here's an example. I'm going to just refer you to this reference in the New England Journal. You have the handout. It's giving you an example of a 62-year-old woman with certain lab findings, family history, etc. And the issue is, how do you deal with this patient with primary hyperparathyroidism? Well, the answer is, there are some guidelines, evidence-based medicine. Criteria for surgery, surveillance without surgery. Those are the choices. First, make the diagnosis. Person really does measure the PTH, inappropriate PTH for the serum calcium, has primary hyperparathyroidism. So how high is the calcium? What is the creatinine clearance? What's the kidney function? What's the bone mineral density? What's the age? How good a surgical risk is the person? So these are the criteria, and opinions are divided. It's really hard to know, even from a cost-effectiveness way, which is the better thing to do. So in this individual, further evaluation and treatment, should we test other family members for FHH? Should we do immediate parathyroidectomy preceded by imaging studies? Should we do annual surveillance for disease progression? Or should we do either 2 or 3? And, I'm recognizing, sorry, did that very rapidly, okay. Sorry about that. But the upshot is 2 or 3 are quite appropriate. 2 or 3 are quite appropriate because the case, and you'll go back and look at the data and you'll look at the guidelines, it's kind of a toss-up. You could make a case for following the person. You could make a case for operating on the person. The reason number 1, test other family members for FHH, and I went by this very rapidly, is not correct because you saw her urine calcium values and they were not in the FHH range. That was embedded there. So I hope you understand that. That's the crucial point. You have to have a certain level of urine calcium to make you suspicious about this. Seem to be going in the wrong direction. Okay, here we are. So the key clinical points: primary hyperparathyroidism, the most common cause of hypercalcemia, most asymptomatic, elevated or unexpectedly normal, simultaneous and elevated albumin-adjusted level is diagnostic. Neck imaging is not indicated for diagnosis. You don't do imaging in endocrine diseases for diagnosis. You make the diagnosis biochemically. You do imaging, if need be, to guide a surgical approach. Then, again, the issue of meeting the criteria, whether you do surveillance or parathyroidectomy. The imaging studies are shown here. We don't have to dwell on it, but there are several kinds of scans and ultrasounds, and you can read through this. So in the differential diagnosis of hypercalcemia, here we have a woman with sarcoidosis. We actually know this, very high serum calcium. She's on thiazides. That's problematic. PTH is undetectable. That tells you right off the bat, this is not hyperparathyroidism. She's got an elevated 25-hydroxy-D and a very elevated 125-hydroxy-D. What's going on? What's going on? Granulomatous disorder, vitamin D mechanism, PTH suppressed. Thiazide may be contributing to how elevated the calcium is. And importantly, the 125 is elevated disproportionately to the 25-hydroxy-D. And that's because the granulomas in the sarcoidosis are giving you this 1-hydroxylase. Here we have a patient that, on top of everything else, was taking some sort of a supplement, and it turns out that it had lots of vitamin D in it. Treatment, IV hydration, bisphosphonates, glucocorticoids, all driving down the serum calcium. No recurrence of hypercalcemia once this treatment was done and the supplements. You have to take a careful history. This is vitamin D toxicity due to a commonly available over-the-counter remedy from the Dominican Republic, actually reported from Washington Heights, not too far away, by colleagues at Columbia. So be aware of these kinds of situations. Sarcoidosis as a granulomatous disease, I've already made this point, gives you a higher 125 relative to 25. And here's another example of supplements and inappropriate amounts of vitamin D causing vitamin D intoxication. Treatment with a bisphosphonate, pamidronate, calcitonin didn't do much, IV hydration, you're driving down the serum calcium. And the calcium in these two cases goes down much more rapidly than does the 25-hydroxy-D because the half-life of the 25-hydroxy-D is much longer. It's a lipid-soluble substance, so you get the reduction in calcium before the other. Let's, in the remaining minutes, and we will get through this, consider hypocalcemia. Clinical manifestations, quite the opposite neurologically: numbness, tingling, irritability, brisk reflexes, Schwastek's sign, the facial nerve. You tap here, and the person gives an involuntary facial twitch. The musculoskeletal trousseaus, we don't do this anymore, a blood pressure cuff, and the person goes into tetany. And the cardiac manifestations. Differential diagnosis. It's either due to hypoparathyroidism or it's not due to hypoparathyroidism. The non-hypoparathyroid causes: vitamin D deficiency, resistance to parathyroid hormone, resistance to vitamin D, certain medications, antineoplastic treatment, pancreatitis can cause hypocalcemia, acute rhabdomyolysis because the calcium actually in a dystrophic way ends up in the bone, tumor lysis. In a consult in the Cancer Institute in my NIH days, treated a person with a form of Burkitt's lymphoma. And the chemotherapy dramatically shrinks all these tumors, which then release huge amounts of phosphate. And the person then lowers the calcium because of this huge phosphate load. So all these are non-hypoparathyroid causes. Hypoparathyroidism can be autoimmune destruction of the gland, congenital because of certain anomalies, or, for example, mutations in the parathyroid hormone gene, which prevent synthesis. Post-surgical would be the most common. Always be aware of neck surgery, thyroid surgery, which has removed the glands. Magnesium deficiency when it's severe, neck irradiation, infiltrative diseases. In the neonatal period, there is transient hypocalcemia and can be hypoparathyroidism. This is very rare now. The hungry bone syndrome, people with severe bone disease in hyperparathyroidism, when they were treated, the bones are now sopping back up calcium and they can actually become hypocalcemic. So that's the differential diagnosis. I was passing this around, so I already told you. This is an example, the Hormone Health Network coming from the Endocrine Society, telling patients what to know about hypoparathyroidism. And you see all of that information. Extracellular calcium homeostasis, the flip side of what we were talking about now. Here's our calcium sensing receptor. Here it's inhibiting PTH. Hypoparathyroidism, deficient PTH secretion, or deficient PTH action. I won't bore you with it. There's actually a disease called pseudo-hypoparathyroidism, where the people are resistant to the action of PTH. They're not deficient, and they become hypoparathyroid. So hypocalcemia, hyperphosphatemia with normal renal function, that is deficient PTH secretion, hypoparathyroidism. Now, here is the flip side of FHH. There's something called autosomal dominant hypoparathyroidism. A mutation, in this case, not inactivating, but activating one allele, green, of the same calcium sensing receptor. What does that do? It left shifts the dose-response curve, just like that drug, cinacalcet, that we talked about. So it inappropriately shuts down PTH secretion at inappropriately low calciums. That is a unique form, a genetic form of hypoparathyroidism. And yes, again, mutations affecting G protein alpha subunit 11, just like loss of function mutations in the calcium sensing receptor and in alpha 11 can lead to FHH, activating mutations in the calcium sensing receptor or in alpha 11 can cause autosomal dominant hypoparathyroidism, hypocalcemia. Hypoparathyroidism is not a picnic to treat. You want to avoid it. This is a so-called waterfall plot showing the proportion of observed time for each individual patient where the serum calcium is in the therapeutic range between 7.5 and 9.5. In yellow, those who are too low. In orange, those who are too high. Each column represents one patient in the cohort. You can see it's quite problematic. And furthermore, if you're not treating well, you're trying to avoid hypocalcemia and symptoms, but you don't want to overtreat because the urine calcium excretion will be high. You'll get nephrocalcinosis, which can cause end-stage renal disease. So you're really treading a fine line. Think about it. This is one of the few diseases where you're not treating the deficiency of parathyroid hormone physiologically. You're not giving parathyroid hormone. What's the treatment? Vitamin D and calcium. Vitamin D and calcium, although it corrects the serum calcium, is not a perfect physiologic replacement. So why don't we give? And this is just showing you further examples of these patients. See, many of them are hypercalciuric. Proportion with EGF, glomerular filtration rate below 60 as a function of age, this is alarming. A significant proportion in black are developing low GFR. So these are people being treated for hypoparathyroidism lifelong with vitamin D and calcium. It's problematic. There have now been clinical trials, and I'm giving you two examples, where you're trying to give human synthetic PTH 1 to 34, which is the active form, versus 125 vitamin D or other forms of vitamin D and calcium. And without going through the details, there is some benefit short term. But the fact is, you have to give injections. Patients don't like injections. We don't have a form yet of PTH that is absorbable or which they could take. This is a problem in diabetes, but diabetes has no other satisfactory alternative, particularly if it's type 1, than insulin injections. This is why companies spending vast amounts of money developing inhaled forms of insulin to avoid the injections that patients hate. These are real compliance issues that you need to be aware of. In hypoparathyroidism, the take-home message is vitamin D and calcium, it's the best we've got that's practical. It's effective, but you have to really monitor the therapeutic line closely. Will there eventually be a form of PTH? Possibly, but we're not there yet. Thank you very much for your attention. Sorry for going over long. And again, I invite your questions via email. Thank you.